Mahmoud. He is associate professor in Cairo University. He attended C3 more than 4 times, and he's one of the upcoming leaders in. I mean, we expect him to be one of the pioneers of intervention soon. He will present an interesting case.
Thank you, Dr. Ahmed, for this nice introduction, and like to thank you again and Dr. Raj for this elegant event. So my case is about acute coronary syndrome in post-CABG patients. A plan to read. Sorry.
Larger slides.
Okay. And he is a 60-year-old male. He has a risk factor in the form of diabetes mellitus, hypertension, and dyslipidemia. His presentation was non-ST acute coronary syndrome in the form of recurrent attack of breast angina over the past 1 month. His ECG showed old anterior myocardial infarction. His ejection fraction by echo is 35% in the presence of mild mitral regurgitation, and he has a borderline GFR of 50 milliliter per minute. So this is his coronary angiogram. In this areocaudal view, we can appreciate it has a distal left main lesion. It's actually a Medina 1-1 cruching in the ostia of the LAD and the LCX. The LAD gives this large diagonal branch that also shows a significant ostial lesion, and we have a retrograde collateral to a totally occluded right coronary artery. In the areocranial view, we can appreciate also the significant disease in the left main, as well as the extent of the disease into the proximal LAD and the ostium of diagonal branch, as you can appreciate here in this still image. The right coronary artery, as we mentioned earlier, is totally occluded at its mid segment. And this is the graft to the right coronary artery. It is totally occluded. He has this nice graft to the diagonal branch. This diagonal branch, we are not sure, is it the diagonal branch visualized from the LAD, or it is another diagonal branch. And the lima was okay and supplying a good, but with a good LAD with some atherosclerosis at its distal segment. So, as I mentioned earlier, I am not sure that is this diagonal branch is supplied by this graft. As we can appreciate here, there is some overlap. So it's my first reading tip. I did a retrograde injection from the right radial artery, and there are 2 different diagonal branches, and we have this. The first diagonal branch is also showed a significant ostial disease, and the second diagonal branch is supplied by this patent saphenous vein graft. So this is the still images for our patient, and this is the targets of our intervention for his symptoms. We have this lesion in the this early diagonal branch and the ostial LAD, as well as the distal left main back to its ostium. So we started with doing a balloon dilatation with 2.5 20 millimeter balloon, and this was a preparatory for IVUS imaging. IVUS here, we felt that the IVUS is important because we have a much discrepancy between the diameter of the diagonal branch, proximal LAD, and the left main. So we felt that we should use the IVUS as a preparatory for the stenting, and actually also after to confirm the adequacy of our results after stenting. So here I'll show a short videos of the IVUS, and you can appreciate here is the diagonal branch. This is the healthy segment of the diagonal branch. Here is the IVUS. This is a short video for this segment of the diagonal branch, and it appear healthy. And this is the site of the ostial diagonal lesion back to the LAD. Here you can appreciate the severe lesion at the ostium of the diagonal branch, and this is the LAD. Back to the LAD, and the LAD actually was huge. As you can appreciate, the LED was very large and had a very large diameter. Actually, it looks at an ectatic segment and the proximal LED. And this is back to the lesion at the ostium of the LED. You can appreciate this is a very significant lesion at the ostium of the LED back to the distal left main. And this is the left main lesion, also a severe lesion, especially at the distal left main, and the black burden is seen back to its ostium, as we see in this short video. So we appreciated our reference diameter, and the diagonal branch is actually large. It's about 3 to 3.5 millimeter diameter, and the proximal LED and left main is also large, approaching about 5 millimeter or 5.5 millimeter. So we start our intervention to the diagonal branch with a 3/20 millimeter everolimus luting stent. We tried not to withdraw the stent back to the LED. As you can remember, this LED is aneurysmally dilated, and we don't want this stent to be under-deployed in this large stent, this large LED. So we deployed the stent back to the just a few millimeter in the LED. And this is the image after the diagonal stent. Then we did a stenting with a 4 or 24 millimeter everolimus luting stent. If we have, of course, a 4.5 millimeter stent, it would be better. But however, the largest diameter at our lab was 4 millimeter everolimus luting stent. So we stent the proximal LED from the distal stent overlapping with the distal stent back to the ostium of the left main. And here is you can appreciate we have still here some waste at the ostium of the LED. Here is the flaring of the left main stent. Then we started to do a post dilatation first. As we know before, the diameters of our target vessels. So we post dilate the diagonal stent with 3.5 20 millimeter NC balloon, and we started dilating post dilating the proximal LED and left main with 4.5 15 millimeter NC balloon. After that, we did after we did that, this is the image after the post dilatation of the diagonal and the left main LED. Then we did an IVAS after the stenting. This is the diagonal stent. It appears okay and will oppose in the diagonal branch. Then the diagonal to LED. Sorry. This is the stent. This is from the diagonal to LED. Again, the stent appears well opposed. And here is the proximal LED. Here the stent is not well opposed and under expanded. So this is the site of post dilatation. We decided to post dilate this part of the stent. And the left main again also needs a further post dilatation. So we used a 5/0 15 millimeter NC balloon and inflated it at high pressure at the proximal LED and the left main. And this was our final images after the 5/0 15 millimeter NC stent. We have some benching of the diagonal branch. However, of the circumflex branch. However, the circumflex doesn't seem to supply major branches. and the patient was fine and with a TIMI 3 flow in this diagonal. So we choose to stop at this stage. So this is my final remark. This is a post-CABG case with acute coronary syndrome. We did a PCI to native vessels, the left main LAD diagonal. Adequate visualization of the native vessels and the graft was crucial. And we did a simultaneous injection from the left main and saphenous vein graft to confirm the need of the first diagonal branch revascularization. IVUS was essential as a pre-stenting because of large diameter discrepancy between the diagonal LAD left main, and also for post-stenting to optimize stent apposition. And we decided to end this procedure as a provisional stenting to the left main. And thank you.
That was a great, presentation. Excellent demonstration of intravascular ultrasound to demonstrate the intricacies of vessel diameter variations between these branches and how imaging helps us resolve some of the decisions regarding the dilatation of these vessels, resulting into a very nice result. And also it's great to see that after IVUS examination, identifying stent under expansion and correcting it was performed as well. A recent study demonstrated that even after imaging study was performed 30% of the time, appropriate step was not taken because the image was not interpreted properly. But in this case, the image was interpreted properly and appropriate action was taken. So it was a great case. Now I'll leave it to Dr. Magdy to make final comments, and any panel members who wants to comment on the case. I know it's late in Egypt and everybody's anxious to go to bed. Yeah.
So I think we had achieved our goals. We had gave presentations. We had 6 lectures. They are mostly evidence-based medicine lectures, very updated in a variety of subjects, not related only to intervention, but also to very important issues in cardiovascular medicine. We had 8 very challenging cases. As we had written, one of the logos is the Egypt Bifurcation Club, and so we do with C3, and also mostly they were in bifurcation, so they were with our goal. We had participants up to, I think, 5,000 were following this webinar all over the world and in Egypt. And I was able to bring Dr. Amin Fouad until the end of the session. He's one of the very, very busy colleagues and friends. So I will give actually 1 minute or just a brief comment from the board meetings who are still with us until now. And so I will start with Amin.
Thank you, Professor Rajesh Dev, and thank you, Dr. Ahmed Magdy, for bringing the C3 as a webinar. And we hope that next year we will be in the States, and then we will have a physical meeting better than this virtual meeting. But at the end of the day, we have a very successful event. We have 6 lectures that was very, very evidence-based, and we have very fine cases and very fine discussion. And I think we all learn from each other. Thank you again. Thank you, Professor Rajesh Dev. Thank you, Professor Ahmed Magdy. And thank you for all the participants. And I hope we'll see you physically in the next meeting next year. Thank you.
Nabil, briefly. Yes. Nabil Faraj.
Thank you very much. I would like to thank Dr. Raj for his great contribution and his collaboration with us. I'm very happy to be with us, Dr. Raj, and actually I enjoyed your comments and enjoyed every word you said about the presentations. And I would like to thank Dr. Ahmed Magdy. Ahmed Magdy is what we call is a very, very active, he's super active actually. He's doing a lot of effort. Is helping a lot of young doctors here in Egypt. Is educating and teaching a lot of young doctors, and that's why I would like to thank him very much. And actually, we use him sometimes in, to make some meetings and some. Thank you, Ahmed, and thank you, Dr. Raj. Thank you, everything. Thank you, everybody. Dr. Amin is actually my dear friend, is my brother, and
thank you
very much. And thank you for this great meeting, great presentations, and thank you all.
Thank you very much. Before I just leave the last word to Raj, so of course Nabil is my associate in the Egyptian Fellowship Board of Intervention Cardiology, which is now coming up. Dr. Amin is helping us. He's one of the board members. And now we are working together in the working group intervention, in the Fellowship Board of Intervention. So I think we are coming up as this community is the leading community in intervention in our area, and we are very unbiased and we are very educational. I think we did our job. Raj asked to have so many cases because he wanted to compensate for people who did not go to Orlando. So maybe you late. We are 40 minutes late, but I was expecting, excuse me if I was hard to finish some of the presentations. And we continue our relation with Raj. He's always he has open invitation to all our meetings, and we have also we contribute to his meeting, and he's giving us a big chance to the young people and to the professors. We still have the picture of the last Egyptian joint meeting with the Sulasi. It's like the last dinner. It's still on our Facebook account. So Raj, if you like to conclude finally.
Well, thank you. Thanks again, everyone. Thank you for very, very kind words, Dr. Amin and Dr. Nabil, as well as Ahmed. You know, all of you are working really, really hard to put all this wonderful education together for countless Egyptian young physicians and the physicians in the rest of the world that are benefiting from this tremendous effort. So I congratulate you all. I just want all of you to know that I miss you all here. We look forward to, hugging you all in US next year when we have a chance to see you again in Orlando and exchange our greetings in person. So until then, I wish everybody a great health, safe rest of the time this year, so that you all have a safety from COVID and your families remain safe with God's graces. I'm sure that we will see you again on another webinar in a couple months. And hopefully we will have a vaccination for COVID, and we'll be able to meet with each other in next June. So thanks everybody, and have a great rest of the evening.
Yeah, just 1 second. Thanks to Eventi, Dina, Adil, and Ashraf. They had a great job. They communicated with all the speakers. All of them who they don't answer their mobiles, but they found a way to reach them. Thank you for arranging. Thank you, Karim. Thank you, Sherif, Hussein. Thank you. I thank everybody, and see you soon when this epidemic is over. And thank you. Okay, shukran ya Dina. Thank you. And pictures, Raj, we will need the lectures that they gave just to send to us, because this will use for education. Thank you very much, Amin, Nabil, Karim, everybody, and thank you for keeping until this late. It's already at 12:30 after midnight. 2 hours of the webinar, 5 hours. Thank you very much. Bye.
Bye.